And have the privilege of Dr. Tim Ihrig to talk with us today. He is a great friend of the fellowship, friend of John's well before I knew him. But if you Google him, he's got a lot going on. He had a TED Talk a few years ago for his 4 questions. So if you've got time to ask him about that later on, that would be great. That's a whole other discussion on its own. But he's here today to talk about dyspnea, and we'll go ahead and get started. Thanks again for coming, Tim.
Hey, thank you so much for the opportunity. And I'm going to dedicate this to my dear, dear friend in the living memory of John Mulder. So we'll talk today about respiratory difficulties. Start with dyspnea. We'll move into cough, respiratory secretions, and hiccups. Same lecture I gave last year. Fortunate enough to be offered the opportunity to repeat it this year and make up for all the errors I presented last year. Anyway, please look forward to a conversation and questions afterwards. So this is adapted from a dear friend and mentor when I was in fellowship out at Stanford, Gary Shin. He's the chief of palliative medicine at the VA in Palo Alto. So respiratory difficulty is something we deal with on a frequent basis. We'll review pathophysiology and treatment symptoms of, again, dyspnea, cough, secretions, and hiccups. So dyspnea. What is it? Physiology, cognitive, emotional factors. So dyspnea is really the sensation of shortness of breath. And anybody who's heard me lecture knows that for me, dyspnea, as well as any other symptom, is a subjective perception, the patient. And it is what it is. And our challenge, our responsibility is to accept it. Our responsibility is to elicit the highest level understanding of what that patient's lived experience is, not just at that moment in time, but over time. How have things changed? And we know that with dyspnea or any other symptoms, it's influenced by a number of factors. And so, again, our charge is to really connect deeply with the individual and understand to the best of our ability what their experiencing is. It's to help them articulate what they're feeling and how we can improve their quality of life. So physiology is not just oxygen. You've all been around long enough to realize that you can have the 70-some-year-old COPDer who kind of lives in the high 80s as far as oxygen saturation, and they feel very comfortable. I've had some people that live in the high 70s, and they don't feel short of breath. And if you think about it, over many, many, many years, their body has adapted. It's much like my 17-year-old son. I don't realize how much he's grown and that he's taller and bigger than me because I live with him and I see him every day. When friends who haven't seen him for years come and they're like, wow, what a change. That COPD isn't experiencing the same thing as the friends who visit and see my son after years. It's to them, it's sudden. The COPDer's experience is my lived experience with my son. It's just very gradual, it's subtle, and it's not really noticed that much over time. So we can't make the assumption that somebody whose oxygen saturation is in the mid 80s is profoundly short of breath. We need to ask them. And again, some people who are saturated 100%, feel profoundly short of breath. And there's a number of reasons that could be. So we have to accept it for what it is, much like pain. We just have to elicit an understanding of the patient's perception. So exercise, we know that, my first attempt at a career 30-some years ago as a professional bicycle racer, and I would be, anaerobic with a heart rate in the 200s and seeing Elvis Presley because I couldn't breathe fast enough. But I didn't have a sensation of dyspnea that many of our patients experience. It wasn't anxiety provoking. I knew that I could catch my breath. Also think about when you were a kid. Maybe you ran across the field or ran down the street to see your best friend, and you laid in the grass and your side hurt because you were breathing so hard. You didn't have an associated anxiety, tension, or fear, but you were certainly short of breath and you weren't hypoxic. Um, we know that opioids also, and we'll talk about these a little bit later, influence our perception of how we breathe. Certainly with a significant amount of narcotics, we can suppress respiratory drive, but generally when used appropriate, the opioids are first line therapy for alleviating that sensation of dyspnea. And again, for our field, right, the sandbox of palliative medicine, it's so important to be able to articulate this, not just to patients and families, but our colleagues who are still in the throes of paralysis and fear from the opioid epidemic, and pre-existing incorrect perceptions of what opioids do. We need to educate them and empower them to understand that these are tools. And generally speaking, patients that we use our pharmacologic tools on, particularly opioids, are not going to be addicted to them, even if we're talking about pain management. So we need to overcome a lot of bias that exists in all fields, patients, families, as well as our providers. The pool experiment, there's actually two things. There's an actual pool experiment by Bernard Schoenhofer in 2004. Said that dyspnea is a common symptom in patients, obviously, with diaphragm weakness or paralysis, and it's aggravated by immersion in water. And the conclusions were relative to control subjects. Patients with weakness had an augmented drive to breathe in order to attempt to kind of defend their gas exchange. So they preserved their minute ventilation and augmented their respiratory rate, even though the exchange of oxygen, because of that diaphragmatic weakness, was significantly different. Another pool experiment, one I learned about in fellowship, was that if you take an average subject that does not have any sort of respiratory ailment, and you put them in a pool and say, okay, go underwater, and they have the ability to control when they come out of the water. So when they feel short of breath, they can come up. Those people have a decreased sensation of shortness of breath while they're underwater. And I think this goes back to something that's really important, regardless of symptom, regardless of diagnosis. We have the ability as providers to give control where control can be given. And so if we increase the sensation, the perception that someone has control over their environment, and for dyspnea, right, if we use opioids as a tool to alleviate that sensation of shortness of breath, people have a greater sensation of control over their lives, less fear. We start to shift that narrative that is so pervasive in our field, the fear of dying, right? Again, not to get off on a tangent, but most of our providers lead with, you don't want to die, do you? That's an asinine question because everybody's going to. Question should be, how do you want to live? And what are the options? What are the tools we have available, pharmacologic, psychologic, whatever they are, to help you live and love and learn and grow and share based on what's sacred to you? So that pool experiment to me demonstrates, when you have the ability to pop your head out of the water and take a deep breath, you're giving control where control can be given. And that's really important. So physiology, if we move on to that, of dyspnea, shortness of breath, we know it's primarily the limbic system. And so there's chemoreceptors, O2, CO2, mu, kappa, delta, sigma. Obviously, these are where the opioids are effective. And all kinds of signals throughout the body: pulmonary vagal afferents, stretch irritant receptors, cough. Again, the person with diaphragmatic weakness, paralysis. I won't go into the weeds too much. Feel free to review your physiology from med school. I think what's really important from this slide is that the limbic system's function is primarily to process and regulate emotive and memory of lived sensation. So it also affects behavior, motivation, long-term memory as well. And so this is generally where our benzodiazepines work. They help to modulate the negative sensation and decrease that sensation of anxiety that often coincides dyspnea. Right? Many of our patients get short of breath, they become anxious, they're more short of breath, they're more anxious. It's a cycle, and a combination of opioids and benzos used appropriately can really help mitigate the escalation of those sensations. So remember, limbic system, if any of your patients ask, doc, where in the brain is this working? So how do we evaluate dyspnea? I just ask people, how you feeling? Tell me how you feel you're breathing. Do you feel short of breath, right? What exacerbates it? Are there positional things that make you feel better? Have you tried anything in the past? Are there emotional things that exacerbate your sensations? So there is a Borg scale, and there are really two versions. The simplest is 0 to 10, a visual analog scale, much like our pain scale, where people can help identify and expound on their lived sensation, the severity of what their shortness of breath is. And I use this longitudinally, particularly in the acute care setting. Somebody comes in and we're starting a pharmacologic intervention, and they're, a 7 on the Borg scale. And we see that change over time based on our pharmacologic intervention. Also compared to, is it making them more somnolent? Are they confused? Do they have nausea? Certainly all these other things that we pay attention to when we are treating any of our patients pharmacologically. Does somebody have a question? Okay. As far as our exam, right? Simple things. What is the rate? What is a respiratory rate? This is really important when people are obtunded, people aren't able to tell us how they're feeling. People who are on comfort measures only, end of life, whether in the home setting or the hospital, we can use that rate to determine, are they comfortable? And usually I aim for a rate of around 15 breaths per minute. You and I breathe generally about 6 breaths per minute. Anything above 15, and I have the general sensation that maybe somebody's working a little hard and they may be a bit uncomfortable, and it's an opportunity to talk with family about pharmacologic interventions. And even the patient who's not obtunded, they may feel comfortable. Again, the COPD who's been dealing with that disease for years say, look, I'm watching you breathe here, and you're clipping along at 15, 16, 17. Yeah. And I see that your work of breathing, right? There's some retractions, accessory muscle use, paradoxical breathing. You've got pursed lip breathing. You can't remember perhaps the last time you felt comfortable and didn't have to work this hard. These medications may be an opportunity for you to feel and live much, much better. Tests, put an oximeter on. For me, the easiest tests are just to watch somebody and ask them. I don't really do any big tests in the hospital like my pulmonology colleagues. And always remember the differential, right? If there's an acute change, what's going on? Is there an infection? Is there an embolus? Do they have a mucus plug? In the context of what their underlying disease is, don't just take dyspnea as something that has progressed over a significant amount of time. We have to be aware of disease trajectories. And again, this is where it's so important to elicit the lived history. Tell me how you've been doing the last few weeks, months, maybe even years, so you can see change over time. Change over time is very, very important for us to discern what's going on and how we can help our folks. So what do we do? How do we help people feel better? We touched on this earlier. Opioids are a mainstay of alleviating that sensation of dyspnea, and they act in the central nervous system to alter, again, our perception of breathlessness. And they also act to decrease anxiety, reduce obviously the respiratory drive, as we talked about, if you give a certain amount, but all of us being diligent and striving to be experts will be cautious not to do that. As an aside, I just have a practice of never stacking a benzo and an opioid together. I've found that the benzodiazepines have a greater propensity to decrease respiratory drive than the opioids, but they can be very effective, and we needn't be afraid of them. I just always space them out. And when I am in a home setting with a palliative patient or a hospice patient, I make sure that patients' families and the caregivers, nurses, are very much aware of this and understand that we separate the benzos and the opioids. Again, not a fear-driven, don't stack them or you're going to stop breathing, but to empower them to understand what these tools can do and how they should be used effectively. As far as which one, how much, how often, which route, this is the art of medicine. This is the art of caring, actually. And so I encourage everybody to be comfortable with a couple opioids. You know, it's like ice cream. There's many different flavors. I'm an old school guy and I'm not real smart, so I just stick with morphine as my first line. It's what I grew up on. It's what I cut my teeth on. It's what I'm comfortable with. Now you can go off and from there do any other opioid that exists, but I encourage you all to find one or two that you're really, really comfortable with, but be familiar with you know, as many as you can, because not all flavors work for everybody in the same manner. There's other drugs, obviously, steroids, nebulizers, antibiotics, diuretics. Again, understand the lived history, understand the disease progression, and tailor your pharmacologic interventions accordingly. I really, really like steroids. However, the asterisk for me is anytime I have a cancer patient, I always find it appropriate to reach out to my oncology colleagues and say, hey, this is what I'm thinking, and this is what I'd like to do for a time limited period to get somebody feeling better. Not that a few days or a week or two of steroids are going to appreciably diminish somebody's immune system in the setting of an already diminished immune system, but it's just good PR for us as a specialty, builds goodwill with our other providers, and it's an opportunity, right? Every opportunity we have to engage, sit down, and talk with our colleagues about what we're thinking and why is a good thing. Oxygen. At some point, certainly, oxygen if you are hypoxic, and that's what's driving your sensation of dyspnea. Adding oxygen in whatever setting, hospital, home setting, etc., is of value. And then sometimes it's just subjective. People may be statting in the 90s on room air, but they want that nasal cannula. It's a sense of assurance. Again, it gives them control, if you will. And so again, education and support, I think, are important. I never say no right off the bat in palliative or hospice. I yearn to understand the why, and then to engage, learn myself, empower others to learn, and then move forward accordingly. So again, the patient who's got a normal oxygen saturation but feels profoundly short of breath, unless they have that nasal cannula on, I want to understand why, and then work with them to empower them to understand a little bit of the physiology and how we can help them feel better, you know, with or without that oxygen. So non-drug therapies, phenomenal. And these work very, very well as standalones sometimes or in combination. I often say, let's just sit down and hold hands and take a deep breath. Let's just try to be calm. Empowering people to understand why they feel short of breath. Much like when people who have pain, this is why you hurt. This is what's happening that's leading to your sensation of this negative feeling. It gives them a sense of control over it. Again, what are humans most afraid of? right? We're afraid of the unknown. And we don't know why we're short of breath. Let's say we don't know why we hurt. It can exacerbate that sensation. So we have a responsibility, and we have an obligation, and we have the power and to allow people to understand what's going on in their bodies. And sometimes that can be markedly effective in diminishing their negative sensations. Energy conservation. What is pulmonary rehab for? What is cardiac rehab for? It's to get you in better shape so your body needs less energy to do kind of the activities of daily living. And so then you don't feel as short of breath. A lot of our people obviously can't go out and train for a marathon, can't even get on the treadmill, but there's things we can do working with occupational therapy, physical therapy, so the people that have lung issues and dyspnea can find different ways of living their lives and not feeling so tuckered out. Obviously, positioning, fans, I find have been phenomenally effective. Just that cool air blowing in the face, or open a window. A lot of times people feel more short of breath because there's this claustrophobia like sense. Non-invasive positive pressure ventilation. I have been a huge fan over the last 25 years. Acupuncture and acupressure. Finding someone who is versed in acupuncture, I think, is a huge feather in any practice. Acupressure, right? There's a lot of maps of the foot and hand that can be very effective and empower people to feel as though they are actively participating in their own care other than just taking a medication if they choose to do that. So don't discount non-Western therapies. Obviously, interventional procedures, thoracentesis, paracentesis, what are the things we can do to alleviate maybe the causes of why somebody's feeling short of breath? Those should be evaluated and exercised as well. I'm just going to pause right there and just ask if there's any questions. Maybe just speak up. Not take a sip of coffee and then move on to secretions.
It's going to hear that theme again, the concept of talking with your patients, understanding the why, meeting them where they're at. So much of this is based in empowerment. Again, knowing that I'm short of breath is one thing. Having someone help me understand the why behind that, there's things we can do. So a lot of themes you'll keep hearing repeatedly throughout the year.
It's so important. It's so important. And recognizing, I'm not throwing all our colleagues under the bus, but rarely.
You mind there's a but there.
What's that?
I got a feeling there's a but coming.
Oh, yes, a big but, a big but.
Big but, a big but.
Most of our colleagues don't explain the why. And I got to be very careful here. Our colleagues, let's say my interventional cardiologists, right? They're great proceduralists. But what is perhaps one of our scalpels? It's language. It's the meter, the verse, the rhyme that is so diverse and fluid in real time with meeting a patient, family, whomever, right where they're at. So it's, PhD level or it's third grade level. And what do we do fundamentally as palliative care physicians that I'd say rarely anybody else does, is we articulate all the moving parts, cardiology, oncology, pulmonology, nephrology, and we make it in terms that the individual who's in front of us can understand and digest. Our colleagues don't do that. Rarely does the cardiologist do it about the heart, nephrologist about the kidney. We're doing it about all the systems together and how they interact, right? And so that is the highest level of care, and I would argue medicine that exists, is understanding the interactions and being able to translate it, right? We are translators, and that is so important. So respiratory secretions, it's tough to get this one right. Not too sick, not too thin. This is one of the things that I just struggle with, and primarily when you have someone with like mucositis, right? If someone has excessive salivation or they're too dry, that's more readily ameliorated. But any of us who've dealt with mucositis, that's just a tough one. And to see people with such a viscous issue, it's horrible to watch them just try to breathe, just try to talk, just try to swallow, just try to live. So, I still reach out to my pharmacist friends for everything, but particularly for secretions. So we know that there's a lot of opportunities, anticholinergics like glycopyrrolate, scope, atropine. As a side note, right, these things are intended to dry you out. You can go so far as to make somebody so parched that they're getting cracked lips and a split tongue. So we need to be very, very mindful of how much and how often. Also, and I haven't looked in a decade, so somebody jump in if there has been some research. Know that scope and atropine cross the blood-brain barrier, and we know that we have, a variable molecular size blood-brain barrier that can change over time. I have seen in my practice that scope and atropine can act to some extent, and I may just be seeing things as somewhat of an anxiolytic, not to the same extent as benzos, but compared to patients who receive glycopyrrolate, I've seen some effects where the scope and the atropine, and I'm assuming because they cross the blood-brain barrier, act to kind of take the edge off of a patient's anxiety. And I don't know if anybody else has experienced that, or it's just an N of one, but just keep it in mind. And through your practice, if you use any one of these, love to hear from you in the future, see what you think. So expectorants, we talked about drying agents, the anticholinergics. There's aerosolized solutions. You can use hypertonic saline, sodium bicarb, beta adrenergic agonists that can be utilized as well. Mucomist, recombinant human DNAs, antibiotics. There are a host of things we can use for almost any symptom. I have found over the last 20 plus years, 99.9% of the time, I'm on that first two line of expectorants and drying agents. I don't know that I've ever written for an aerosolized solution. Fortunately, I've never had to. I'll go to the hospital today, and this will be the first day because I just talked about it. But know that these things exist. And again, I can't stress enough that partner, know what you know what you don't know the difference between the two, and don't get stuck on this is what I've always used, so it has to work. Like I said earlier, I am always reaching out to my clinical pharmacist, even if I know this is what's working and this is what I'm going to utilize. I sometimes reach out and just talk it through and say, what other options do we have just in case?
Yeah, and Tim,
Go ahead.
I'll say that I use nebulized hypertonic saline quite a bit, particularly with the Parkinson's and ALS patients with the thicker secretions. 4 milliliters in a nebulizer machine is all you need. You can do it 2 or 3 times a day. Works great to break those secretions up. Works even better with a cough assist or suction.
Excellent. And again, I'm going to walk in today, and that's going to be what I'm going to have to use. So I'll call you just talk me through it again. So, and this picks up a great point, right? I am an N of one, right? This is my lived experience, and there's a host of knowledge about things we can use, things we can try. Don't just take my word for it, right? You, as in training and fellowship, you are exposed to a host of people with, collective experience. Make sure you talk with as many people as you can. Non-drugs, you just mentioned suctioning, chest physiotherapy, positive expiratory devices, pressures, masks. Hydration is one thing. Can dry somebody out, but make sure that they're hydrated as well. And then again, this one gets sticky if you got someone with, say, heart failure, and they're dealing with a lot of secretions, and so you dry them out and they're really, really thirsty, and so then they're drinking gallons of water. It's a cycle. So again, this is education, and it's being accessible to the patient and their families, to talk through changes that may be happening and empower them to understand, this is your disease process, and let's find a middle ground so we're not in the Sahara Desert, but we're not in the middle of the Pacific drowning either. More non-drug therapies, oscillation devices, the flutter valve, inexpensive, and keep in your pocket, can be used to help promote coughing up and getting rid of a lot of secretions as well. So the proverbial colloquial death rattle. What is this, and what do we do about it? Again, I'm going to go back to educate, educate, educate. I can't tell you, at least 3, 4, 5 times a week I walk into a room and family is witness to an individual's change, particularly at the end of life. And they hear the death rattle, retained secretions in the hypopharynx. And I think also physiologically, I try to explain it that as the body breaks down, as this is a natural expected process, fluid kind of goes where it hasn't been before. And so what you're hearing is that fluid kind of outside of its normal place in the body, and to the best of our knowledge. It's not painful, and it's not caustic or consternating to the individual. Does mom look comfortable? Yeah, all right. This is really horrific for us because we hear that gurgle and that rattle. My experience is a lot of times all the pharmacologic interventions we have don't do much for the death rattle. I'll share a personal experience. I cared for my wife's stepfather at our house here about 9, 10 years ago, and he had dementia. And as he was actively dying, he had kind of a smaller, quieter death rattle, but then it acutely changed to where you could hear retained secretions from the other room. And I think what happened is he probably suffered some sort of cardiac event and lost his circulatory drive, and everything backed up, and he went into florid pulmonary fluid overload. There was not a thing I could do. He was gurgling, and it sounded as though he was drowning. He looked completely comfortable. Our opportunity, ladies and gentlemen, is to understand that these things happen and to come to those acute changes with calmness, confidence, and compassion. It was taking my mother-in-law's hand and saying, this is not a high-level physiology terms, but this is what's happening. And does he still look comfortable to you? Yeah, he does. Okay. And I think he is as well. And so it's to walk that journey calmly with everybody involved. It can really make a difference. So that their lived experience or their loved ones' last moments is not fear and panic. Dry mouth. Things we can use: sugarless gums, candies, cholinergic agents, saliva substitutes, optimize oral hygiene, simple things. The patients could do themselves, or when we're approaching end of life, empower family and caregivers to do. Swab the mouth, keep it moist. This does several things, right? You increase the connectivity between the loved one and the patient. They are experiencing a progressive sense of loss of control as well. And that's paralyzing at times, and that's full of fear, potentially. So if you say, look, these are some things you can do to nurture and care for your loved one, there's power in that. They're not just idly sitting by feeling hopeless and helpless and afraid. Now they're actively doing something to care for their loved one. And again, it can be very, very powerful for all parties. Pause right there real quick, see if anybody has any questions, comments, or philosophical observations.
Segue on what he said there about empowering family members. Same with feeding, right? My God, they're not eating. Should we put a feeding tube? Take a little sponge while we're drying the secretions, dip it in their favorite beverage, favorite ice cream, whatever it may be. Again, this isn't about nutrition or sustenance. It's about empowering family members to do something, their engagement.
So I'm giving you a virtual hug for that segue, because I know this isn't about nutrition, but remember, ladies and gentlemen, as human beings, right, there's two sides of nutrition. So I teach the med students, residents, and fellows. There's the physiology, right? And physiology is going to change over time. And at a cellular level, all of the assembly lines in our cells that do the work of keeping us alive, those change. Now, cancer, dementia, heart failure, right? Those exacerbate and those accelerate that change over time, the decreased effectiveness of all these assembly lines. And I'm talking about mitochondria, ribosomes, right? At some point, the cellular nutritional utilization capacity at a physiologic level starts to diminish, and at some point it ceases to work. So we understand that. How do we tell when that is? Well, we got some insight, albumin, pre-albumin. You got pre-albumin to 7 and a non-hepatic dysfunction patient, right? Their lived experiences, they've just been losing their appetite over the last 12 to 18 months. They don't feel like they're suffering. They're not hungry. They've had 60-pound unintentional weight loss. So we understand the physiology is change over time, and Mother Nature is the gift is saying they're just not hungry. Because what happens when you eat? Wow, I ate a whole sandwich and I got sick. I was cramping. I was throwing up. Okay. So now we know that the body's just not capable of processing those nutrients, digesting, absorbing, transporting, cellular uptake. So our charge, right, is to relay that in layman's terms to the family, because they say, I don't want dad to starve to death. But what is feeding? It's emotional. It's this proverbial bowl of chicken noodle soup. Dad, eat this. Get stronger. I love you. It's trying to control an uncontrollable situation. So like you just said, when we understand all these changes and we can translate that, Dad, are you suffering? No, I don't feel like I'm starving to death. And we can say, yeah, Dad's not experiencing what we think of starving. He's hungry, he can't eat, right? That's not happening. Dad's not hungry. And this is a normal, expected process and is natural. And so to find alternative means to help people nurture, which is what that chicken noodle soup is, again, we give control where control can be given. And I love the ice cream thing, right? Dad loves ice cream. He's diabetic. We can't give him ice cream. Why not? Give him all the ice cream he wants. He's not going to eat a gallon. He's going to have a bite of it. And even if he runs a little sweet, right, that's fine. So thank you for that.
And for the record, buttered pecan.
I'm going plain vanilla.
Is it on your advanced directives? Is that what you're saying?
I can't tell you the number of times I had a student with me. I say, be prepared. I'll ask the question. Yeah, I like ice cream. What's your favorite? Buttered pecan.
Oh, I thought it was okay.
It's grandma's favorite.
Yeah. Yeah. Goes back to like the core memory.
Write that down. You'll see it on your boards.
Pistachio.
Yeah.
It's too like
Chocolate chip.
I think you'll see that on the biased boards.
Yeah.
That's what it is.
Too bad.
implicit bias.
Yeah, exactly. So cough, right? We know that cough is a defensive reflex, and we all cough. Airway irritation, whether it's something inside or outside. I moved to Oklahoma 8 years ago, and I never had allergies. But this time of year and about mid to late April, I am just coughing my head off like a 5-pack a day, 75-year smoker. It's just ridiculous. What do we know it's causing, right? Irritation, phrenic, spinal motor neurons, recurrent laryngeal. And so again, here's where an understanding of anatomy, right? Neck bone connected to the shoulder bone. understand if a disease process is affecting any of these things, that can be the etiology of why somebody's experiencing a cough, recurrent cough, or a change in that sensation. Now, there's a good cough, right? Good volume, intrathoracic pressure, clearing out the gunk. A lot of our patients don't have the strength for whatever reason. So we can assist them, right? We can pharmacologically and from a positional and physical therapy, occupational therapy, assist them in creating as much good volume and intrathoracic pressure as possible. Good mucus and ciliary action, right? Nebulized opportunities for our young patients with pulmonary issues, touching on what you spoke about earlier for ciliary action and clearing out secretions. So just keep in mind anatomy, keep in mind disease progression and what may be influencing the lived experience of the patient. So what happens if you get chronic and persistent cough, right? Well, you can hurt, man. The intercostal muscles, they're tiny. And if you're constantly stressing them, you can pull a muscle, you can hurt, you can have a cracked rib, you can be tired. This can exacerbate sensation of dyspnea. You can cough so hard you've thrown up. It can keep you up. It can wake you up from sleep. You know, I'm getting to the age where if I cough too much, I got to be worried about this last one, a little bit of incontinence. So everything can be tied together. And remember Occam's razor, right? What is the one thing that's driving all of this? And how do we relate it together? How do we translate it to the family, to the patient? And what opportunities do we have to care? So I've always found it ironic, and this goes back to the person I'm thankful for a majority of these slides from Gary Shin. A lot of the over-counter medications for cough are cough suppressant and expectorant combinations. So it's like putting a humidifier and a dehumidifier in the same room, right? It just negates each other. So we have to be mindful of what people are taking at home. We have to educate them as well. So protussive, things that are going to help people cough. Guaifenesin, the hypertonic saline, as mentioned earlier, beta agonists, mucolytics, chest physical therapy, vests, etc. for our neural patients. What is the need? Is the need to get something out, right? Are they coughing because they've got secretions, or is there an irritant that's keeping them up and we need to suppress the cough? So it's really discerning what the heck's going on. Protussive treatments, important to have in your tool belt. Antitussives, right? Opioids. Opioids can be fantastic if someone has a non-productive cough that's just driving them nuts and we can't really ameliorate it. Let's say there is something with the recurrent laryngeal, or there is something that's irritating elsewhere in the pulmonary system and is causing them to be short of breath as well. And the coughing exacerbates the shortness of breath. So remember that opioids can be a bit of a cough suppressant. Codeine, hydrocodone obviously is an opioid, and methadone. I've never particularly used methadone in this fashion. I know that others have. I tend to use methadone more of a neuropathic, non-neuropathic combination, pain medication, but not so much as needed for coughing. I think there's other opportunities just because of methadone's pharmacodynamics. I'm hesitant to pull the trigger on this because patients, I trust them. I guess I just don't trust the medication. I trust the medication when used appropriately. We'll say that. I'm a big fan of methadone. More, right? List goes on and on. Tessalon pearls, dextromethorphan, lidocaine nebs, bupivacaine. I've never used any SSRIs in this setting, but it has been used by colleagues. Anybody have any experience with that for cough? Maybe I'll just remove it from the slide. Maybe it's just an anomaly. Decongestants, antihistamines, bronchodilators, right? Don't forget the simple things. Maybe somebody's got some reflux, EPIs, antacids, again, steroids, radiation therapy, etc. You've got a tumor that's in the lung and irritating the recurrent laryngeal. Is there an opportunity to shrink that with radiation therapy? Again, dialogue. Every opportunity I have to dialogue with my colleagues, I take it. One thing that everybody will experience at some point in their career is the potential for massive fetal hemoptysis. And this is really in those cancer patients, esophageal, gastric, pulmonary, that are sitting on some big vessel. And my experience is it doesn't usually just quietly erode through a major vessel in the middle of the night or the afternoon. It's secondary to somebody who's having a coughing fit with the increased thoracic pressure, and then all of a sudden you pop a major artery. Again, this is our opportunity to proactively empower people and say, look, you have these issues that are affecting these particular anatomic parts. Now, there may be a time where we start to see some blood. There may be a time where there's a lot of blood. Keep in mind, ladies and gentlemen, blood is like urine, is like water. It's a fluid. It's just inexorably tied to Friday the 13th and horror movies, and it scares the heck out of everybody. If somebody sees a lot of mucus or somebody sees somebody pee in the bed, no big deal. You see a lot of blood coming out, can be very, very frightening. Again, I empower proactively people to use dark towels, dark pillowcases, dark sheets, right? Because bright red blood on a white pillowcase is a lot more disturbing than blood on a black pillowcase. And again, being the voice of reason and calmness is very important. And then to empower the caregivers if this starts to happen, right? Here's steps 1, 2, and 3 from a pharmacologic perspective you can do. And the reality is, if someone experiences this, they've got minutes at most. I mean, it is the end game. And to articulate that to caregivers as well, so that they can remain as calm and caring and nurturing as possible, is important. So when those individuals who may be dealing with this look in the eyes of their loved ones and their loved ones are calm, that helps them remain very calm, more calm in such a traumatic situation. Midazolam can be used. Obviously, there's other agents that can be used as well. Any comments on the fatal hemoptysis? Anybody experience that? You guys are a quiet crowd today.
As you're going into hiccups, I was going to ask if Thorazine could be used for the intractable or for the cough, if it's suppression of the diaphragmatic part of things. I didn't know if that had ever been thought about.
It has been. I early in my career, I was, I think, so much fear was put into me, utilizing Thorazine.
Oh, really?
I've used it a couple times for hiccups. I've never used it for cough. I don't know. Has anybody?
Very similar methods.
presentation?
Bad idea.
I've
Yes.
not ever considered it for cough.
Well, I guess, as we always learn, it's for those intractable hiccups, which is supposed to be some sort of diaphragmatic spasm. And I figure cough has to somewhat fall under that. I mean, obviously it'd be like super intractable after the other things, but just.
And I think fortunately I've never had to get there.
Yeah.
Right? I've been able to use other things, but that. All right. So I'll pull what I do to my residents. If you could get back to me by Friday with like a 3-slide PowerPoint on any research for Thorazine and coughing, that would be great.
Hey, ChatGPT, I'll do it right now and I'll get it back to you in 3 minutes.
Yeah. Here's the problem, right? If it doesn't know the answer, it's just going to make something up.
Oh,
So
Exactly. So I'll have something for you by Friday.
Yeah. Okay. Yeah. I don't know what kind of medicine you're practicing up there in Michigan, but That's a good question.
Not quite sure.
So I mean, great segue into hiccups, right? It's a reflex. You know, it's afferent input from phrenic vagus, thoracic sympathetic, central mediators, cervical spine, brainstem. So the people I've had with unstoppable hiccups are people who primarily had lung or brain tumors. And I can count on one hand over 20 plus years where I've encountered this. And again, it can be temporary, you know, just a day or two. We define as persistent, greater than 48 hours, intractable, greater than a month. And we're going to get to your slide here in a second. So, you know, let's try to understand what's going on. We can have GI take a look. It could be that it was exacerbated because they got an EGD, and all of a sudden somebody has hiccups for a while. It can be effusions, tumors, etc. Multiple sclerosis, cerebral vascular accidents. Like you said, CNS tumor, sarcoid is one when it affects the pulmonary system significantly. Metabolic, toxic. A lot of times we just don't even know what's causing it, right? People just have hiccups. So what do we do about it? Most of them relieve by themselves. My first line treatment is I try to scare them, right? Like we do at home. Somebody has a hiccup, just try to scare them. I never turn them upside down and have them drink a water. That's just a little too cumbersome and difficult. Just know that most of them are resolved spontaneously. Now, there are any number of things you can use. I am more inclined to lead with Haldol. I'm much more comfortable with Haldol than Thorazine. I've used Thorazine once in my life, but only in the inpatient setting. And then somebody who was within the last 72 to 96 hours of end of life. So call pharmacy, talk with all your colleagues, because some people will see that Thorazine on the MAR and they get really antsy. So anybody want to comment on what they've used for hiccups? Again, I've been fortunate. There's been less than a handful of times, and it's really not been more than 24, 48 hours that I've had to deal with it.
It might be kind of silly, but in the hospital as a nurse, I would give people a scoop of peanut butter.
Really?
And for some reason that would work sometimes. Not every time by any means, but for some reason a scoop of peanut butter.
I've heard that before.
Does anyone suck on that?
Crunchy or
Is it
It's
chunky
something
or
with like
smooth?
the bagel or something. I think
It's the hospital peanut butter. It's that smooth Jif little
Sure.
spoon.
that's Jif.
Yeah.
It's a little packet.
Yeah, the little.
Yep.
Okay.
That's all you need.
I'll give it a shot if it ever comes up.
Little dabble
And
bit.
along those lines, you remind me of, right, when we have excessive secretions and really viscous secretions in fellowship. I'd read some random article, and I have not been able to relocate it, where organic honey, when someone who has mucositis, just a teaspoon of organic honey, and it's been very effective a couple times, and I'm just postulating there may be some enzyme in the organic honey that helps decrease the viscosity of what's going on in the airway. So I'll take the peanut butter trick if you remember the organic honey trick sometime.
Deal. If only
All
they would
right.
stock that in the hospital.
Yeah, really. Soft palate stimulation. I'm gonna add peanut butter to this for the next presentation. All right, for the next time. So that's all I got this morning, folks. I think the most important thing is, again, this is my tagline. We have the opportunity, I'm going to stress it, to be a different voice in healthcare so patients can find their own. And how do we do that? We ask questions. We elicit a higher level of connectivity. We learn the lived experience. We accept it, and we translate and empower people to live rather than trying not to die. And we take it one day at a time. Any questions? Comments?
Hey, this is Rachel from Peds Palliative. We have a patient currently who's getting a bone marrow transplant for, I think, AML, and he has hiccups, unfortunately, for the last probably 5 days. Sorry for my kiddo in the background. And we have him on gabapentin and baclofen right now, I believe. And if any of my other colleagues are on, please correct me. But he has pretty bad mucositis and is really in the thick of his bone marrow transplant. And so we are trying to avoid our antipsychotics because he's getting numerous other meds and things that would be contraindicated. And so I don't know, we're just struggling. So I'm going to maybe suggest the honey and peanut butter and see where we go from there. I don't know. All that to say, we're struggling.
Well,
Sorry.
I would offer caution with organic honey, right? If you are immunocompromised, I mean, caution with anything if you're immunocompromised.
Yeah.
I don't know. I'm going to defer to smarter people in the audience. Talk with
peanut butter safer, I guess. Then, yeah.
Yeah, and get your clinical pharmacist involved.
Tim, I'm going to ask you to stop sharing.
Oh.
That way we don't have the mirror effect. Now we can see you much better.
Oh, well, I'm sorry for that. It's not much to look at this morning.
For everyone,
yeah.
Hey, this is Ken Hansen. Can you hear me okay?
Yes.
Yeah.
Mucositis. Have you tried ketamine switch and swallow? Just 5 milligrams, and then you shoot it. If they're having pain,
doing really well from a mucositis perspective. That is being well treated. It's more he's also super nauseous, has VOD. So we're giving him lots of antiemetics and whatnot. So we don't want to layer in. Yeah.
As far as the hiccups, I don't have any answer. There is something on the market that's called it's like a straw that causes diaphragmatic contraction. And so they try to drink a liquid, and it causes that kind of, but I can't remember the name of it. So
that's creative. I love that. Thank you.
I just put in the chat. This is obviously anecdotal, but if you plug your nose and your ears and drink at the same time, this works every time for me personally, and every time I've ever suggested it, it's always worked well. So. For the hiccups? Yeah, for hiccups.
You need a partner.
Hey.
I mean, it's worth a shot, right?
Absolutely.
Well, I've also wondered about carotid massage, just anything to stimulate the phrenic nerve and get more of the parasympathetics going down into the diaphragm.
Which is why I think the peanut butter works.
Which is why probably the peanut butter works, and maybe even the straw and all these other things we're talking about.
And when my wife gives me the sleeper hold, that works.
Stop hiccups every time.
Yeah.
And
a lot of other
stress.
stuff. Stops me talking.
Well, I've